Good evening, everyone, and welcome to the webinar on the theme Onco Summit 2025. It gives me great pleasure to invite our program director, Dr. Bhushan Nemade, consultant clinical oncologist from Nasik, to give the opening remarks and context setting. Over to you, sir.
Yeah, thank you. Thank you, Himanshi. So, good evening to all and welcome you all after this Diwali, post-Diwali session. So, today we are having 2 hours program named as Onco Summit 2025, where we will be discussing there are three lectures and two very interesting panel discussion. So, the flow would be, we will be having our first lecture on a biliary tract cancer. So we have a very eminent speakers all across Mumbai, Nasik, Jabalpur, Indore, and Chhatrapati Sambhaji Nagar. So our first topic for today's discussion is real-world evidence for Durvalumab along with GemCis as the standard of care in advanced biliary tract malignancy. Over to you, Adwaita.
Thank you, Bhushan. I think this is a very crisp event which focuses on the role of Durva GemCis. Uh, right, just a second. So I hope the slides are seen, and I hope the slides are seen here.
Yes, sir.
Yes, sure. So what I'm going to be discussing in the next 20 minutes is setting the tone for what the discussion is, looking at the real world evidence of Durva GemCis as a standard of care in advanced biliary tract carcinomas. And now it begins with infancy, where all of us have used in our patients this novel immunotherapy in combination with chemotherapy for patients with advanced BTC. So the discussion in this talk is going to be briefly touching on the epidemiology of the BTC, current management of advanced BTC, immunotherapy in first line after TOPAZ trial outcomes, and some real world evidence. So Globocan 2022, this is the India fact sheet where it places gallbladder biliary tract as 19th commonest cancer with 21,780 cases. However, mortality-wise, it ranks 15th most common cause and close to 16,500 deaths. In terms of 5-year prevalence, we see that there are about more than 36,000 people living with the disease at any point of time. And this is what the cancer statistics also show, that in males about 12,300 cases, females 19,000 cases. So 1 in 340 is what the cumulative risk is. Now, in terms of regional prevalence, this is a retrospective study conducted at the Command Hospital in Lucknow. Total 246 patients with gallbladder cancer were diagnosed during the study period, of which 2/3 were women. Majority of the cases were from the state of Uttar Pradesh, with highest number coming from the eastern districts closer to the Gangetic Belt and the tributaries. In terms of age and gender, there has been an increasing trend for incidence of biliary tract cancer in both males as well as females over the years. And a high index of suspicion is required even in younger patients, especially in areas where the incidence is high. This is the 25-year gallbladder cancer incidence data from the Cancer Registry of Delhi in 2020. And this is what is predicted, that from 2000s, about 972 total incidence cases in males, increasing to 2,600. And in females, the total incidence of cases from 1,400 in the late 1990s to close to 6,000 cases in 2022. In the past 25 years, about 12,400 gallbladder cases have been registered. 3% of male, 6.5% of female cancer cases at the center, and a median age of diagnosis was 60 years and 57 years in males and females. An overall trend shows an increasing risk of gallbladder carcinoma incidence over the last 25 years. Now coming to the current management of advanced BTC, Durva plus GemCis is the first line recommendation by the ESMO for metastatic BTC. In terms of therapy options, we do have Currently, we all do molecular profiling for all locally advanced and metastatic cases to look for multiple different targeted therapies as have been enumerated in these ESMO guidelines. So we have IDH mutations, we look for the FGFR2 fusions, the BRAF, the MSI high or deficient MMR, HER2 overexpression or amplification, NTRK fusions, the RET fusions, and the BRCA1, 2 or the PALB mutations, which can be targeted by various targeted therapies and immunotherapies which we have in our armamentarium today. In terms of the NCCN practice guidelines, Durvalumab as first-line therapy for unresectable GBC is also recommended. It gets a category 1 recommendation as a preferred regimen for Durva GemCis as category 1. And also in certain based on the evidence, Durva or Pembro GemCis are preferred regimens for all patients with advanced BTC, including those with MSI high or deficient MMR status. The Topaz 1 study, which was published in 2022 in the New England Journal of Medicine, was a phase 3 randomized double-blind placebo-controlled multicentric global study for first-line therapy in patients with advanced biliary tract cancer, and these included patients who were previously untreated, unresectable, locally advanced or metastatic disease at diagnosis, or these patients had a recurrent disease more than 6 months after curative surgery or after completion of adjuvant therapy. In total, 685 patients. We were randomized 1:1 to Durva GemCis, followed by Durva maintenance until disease progression versus GemCis and a placebo, with a primary endpoint of overall survival and secondary endpoint of PFS, overall response rate, duration of response, disease control rate, and multiple other PK studies and health-related quality of life with safety and tolerability evaluation. So when we look at Durva plus GemCis, this is the first and only approved IO chemo combination to show a 2 years sustained durable overall survival benefit. We see that with the addition of Durvalumab, the median overall survival hazard ratio is 0.76 and a median follow-up time of close to 2 years. Median overall survival with Durva GemCis is close to 13 months as compared to 11 months in the GemCis arm. When we look at the time point data, 12 months, the difference is 47 versus 54. At 80 months, it's 24 versus 34. And at 24 months, the difference is 11% versus 23%. This also demonstrates a statistically significant and superior progression-free survival, which was one of the key secondary endpoints against GemCis alone. A median PFS of 7.2 months versus 5.7 months. Hazard ratio, again similar, 0.75. 6 months PFS close to 58%, 9-month PFS 34%, and a 12-month PFS of about 16%. So IO plus Durva plus GemCis showed significant superior overall response rate in patients remaining in response beyond 1 year of therapy in BTC. And that is what we see in terms of overall response rate. Durva GemCis 26%. And when we are looking at just the chemotherapy, about 18% patients, 2% patients in CR, 24% patients in PR, as compared to none and 18%. In terms of duration of response, there is a median duration of response of 6.4 months with the Durva and GemCis, and a time to response taken is about 1.6 months. The patients who responded continued to respond better, and they did so for a few years. When we look at patients in CR and PR with Durva and GemCis, the median overall survival was close to 19.5 months, and the hazard ratio was still better in that group. When we looked at the overall group, it was 0.76, but in this group, patients who achieved CR or PR with Durva GemCis had a hazard ratio of 0.69. So these are the responders, and these are the patients who are going to do well. The 24-month overall survival was close to 40% in these group of patients, and overall survival hazard ratio 0.69. The benefit of Durva plus GemCis was seen across all subgroups, whether it's male, female, age, irrespective of the PDL1 status, whether the tumor location was intrahepatic cholangio or extrahepatic cholangio, and also in terms of whether patients had locally advanced disease or metastatic disease. In terms of tolerance, the addition of durvalumab did not add significantly to the toxicity profile. We do see similar treatment-related adverse events in both these groups, very minimal differences by addition of durvalumab. So safety profile was similar in both the arms. Any adverse event leading to discontinuation or death also similar in both these arms. Treatment discontinuation probably slightly higher, but this is just numerical. So discontinuation rate for any treatment component due to adverse events in the Durva group was seen in about 13% patients and in the placebo about 15%. And these were the main reasons for grade 3, grade 4 adverse events, mainly in the Durva GemCis, where the anemia, neutropenia, thrombocytopenia, which were the most common even in the chemotherapy group. So the Topaz 1 then came in, which looked at impact of mutational status on efficacy outcomes. This was an exploratory analysis evaluating the genomic alteration landscape of biliary tract carcinoma patients, looking at TP53, CDKN2A, CDKN2B, MTAP, KRAS, ARID1A. These were the most frequent genomic alterations. And in terms of clinically actionable alterations in IDH1, HER2, BRCA1, BRCA2, BRAF, and FGFR2 were also observed. So when we look at the impact of Durva-Cis based on these genomic alterations, Durva plus GemCis is generally effective in patients with actionable mutations also. Generally, a similar overall survival benefit with Durva versus placebo was observed. In terms of the 95% confidence interval, these are wide for certain genomic alterations, mainly because of the low prevalence. So, however, in terms of overall survival, this subgroup analysis is exploratory. That's the caveat for this, and all these should be interpreted with caution. There have been multiple real-world evidences for Durva and advanced PTC. There has been various publications, both by the Italian group as well as groups from India also, where we have our own colleagues from various parts of the country, where we have published a real-world multicentric data from India for Durva and GemCis in advanced BTCs. This is the Italian study, which looked at 145 patients. Patients who had undergone surgery were formed about 28%. Liver enzymes were normal in almost 40%, and 60% of the patients were intrahepatic cholangios. Median PFS and overall survival were similar to the Topaz 1 result data. We see a PFS of close to 9 months, overall survival close to 12.9 months. The Italian real-world update, 666 patients across Europe, Asia, and the USA. 39 sites, 20% had gallbladder cancers, 76% with metastatic biliary tract tumors, and a median PFS of 8.2 months and median overall survival of again 15.1 months. This has been the comparison between GemCis versus Durva and GemCis. So again, immunochemo versus chemo alone. And we see the Kaplan-Meier curves favoring the addition of immunotherapy with a very good hazard ratio of 0.59. So adding Durva does seem to improve the overall response. The adverse events in all of these studies seem more likely due to chemotherapy rather than the addition of durvalumab. Now coming to the Indian data, this is by our colleagues across various centers. 148 patients, 75% patients with performance status of less than 2, and close to 63% patients had gallbladder malignancies. These predominantly presented as de novo metastatic disease. in more than 75% of patients. So intrahepatic cholangio, 27%, gallbladder cancers, 63%. In terms of upfront metastatic stage, 85% patients, lung, the peritoneum, and the liver being the three most commonest. PD-L1 positivity was only in 7% patients, and in almost three-fourths of the patient, it was not done. TMB high, information available for only 10% patients. And in terms of molecular marker, IDH1 and FGFR2 mutations were in a minority. So significantly higher proportion of gallbladder malignancies, higher metastatic burden, and patients with PS2 or higher were also included. Again, we see that when we look at all comers, PFS is 8.2 months, median overall survival about 12 months. And this is despite the heterogeneity of the trial population, which was different than what was included in Topaz 1. Adverse event profile also similar. Any grade 3-4 toxicities seen in only 7.4%. Immune-related skin, hypothyroidism, hepatitis, pneumonitis, all together in less than 10% patients. So the conclusions from the real-world evidence, it appears to mirror the survival from the Topaz 1 study. Median overall survival is 12 months, PFS is 8.2 months. There is no new safety signal. Patients with poor performance status also seem to tolerate the addition of Durvalumab well. And this is an Indian data which confirms that even gallbladder cancer can perform reasonably well with the addition of Durvalumab to standard chemo. So in conclusion, the Topaz 1 study establishes Durva plus GemCis as a standard of care for unresectable BTC. Adding Durvalumab to GemCis does not worsen the toxicity profile. The combination is effective in patients with clinically actionable and high prevalence genomic alteration. And we have real world evidence from India, which also confirms that addition of Durvalumab to standard chemotherapy does improve outcome for gallbladder cancers. I thank you all for a patient listening, and I'm back to you.
Yeah, thank you, Adwait, for a nice overview of locally advanced and metastatic biliary tract malignancy. So I would be going for the second topic. So the second topic is the panel discussion on selecting optimal therapies for SCC in current era. And the moderator for this is Dr. SP Shrivastava. Everybody knows Dr. SP Shrivastava. Dr. SP Shrivastava is a consultant medical oncologist from Indore, currently working at Kokila bin Dhirubhai Ambani Hospital. So Dr. Shrivastava, over to you. You can introduce your panel, or shall I introduce for you?
Thank you, Dr. Bhushan, for a crisp introduction. I will introduce my or invite my panelists for this session. So thank you, organizer, for providing this opportunity. So I think so everybody would be there or should be there. Dr. Shailesh, Dr. Adwaita Gore, he's a senior consultant medical oncologist, already discussed about BTC. Dr. Anup Toshniwal, he's a associate professor from Department of Medical Oncology, GCH Chhatrapati Sambhaji Nagar. Dr. Sandeep Ishi, Dr. Consultant Medical Oncologist from Apex Wellness Hospital, NIMS, Nasik. Dr. Nagesh Madnurkar, Consultant Surgical Oncologist from Nasik. Dr. Shyamji Rawat from Jabalpur. So I think so everybody is there.
So Dr. Shyamji Rawat will be logging in shortly, sir.
Okay, then I think so he will join us later on. Let me share my slide.
I think he has logged in. Shyam has logged in.
Okay. Okay, my slides are visible?
Yes.
So good evening, everyone. So my work is to be discussed on the optimal management of first-line advanced metastatic hepatocellular carcinoma. So this is the basic epidemiology of hepatocellular carcinoma. Data from the India, as we know, it is the 11th most common cancer type and 8th most common cancer for cancer-related death, with hepatocellular carcinoma being the second most common cancer death in the men. It is the data from Globocon 202 India. The incidence was almost 38,703, and almost more than 90% patient died. So it's a fatal disease. It is data from the NCRP Cancer Statistics 202 from India. Men has a higher incidence as compared to the female in the ratio of 4:1. Median age is 40 to 70 year, and cirrhotics has a higher incidence of hepatocellular carcinoma. So that was the basic epidemiology. So let's see exactly what we found in our clinical practice. So my question starts with Dr. Advait and Dr. Shailesh, that what is the percentage distribution of child pug score in your clinical practice, and what is the percentage distribution of patient with BCLC B and C stage in our clinical practice, what we use routinely in our clinical practice?
So, Dr. Srivastava, I think what we see in clinical practice is very few patients come to us in a child pug A situation. I would say if I have 100 patients, there will be only 20% patients who come to me with a child pug A, child pug A cirrhosis with an HCC. Majority of them are child pug B. In child pug B also, I prefer to divide them between those early Bs and late Bs. The early Bs are actually more common, where you have 7, 8 as your score. They would form about 30%. There are about 20% who come with an advanced child pug B, and the remaining 30% would be child C, where we can't really offer much treatment.
So, Dr. Advait, do you use these, parameters in each and every patient in our clinical practice? And what is your common parameter you are using, BCLC, child pug, or LB score?
So, from ease of calculation point, when we look at what's the easiest thing to do when you're actually seeing a patient, and most of these are referred to us by either gastroenterologists or surgeons because they are the ones who see these patients first. Child pug staging is something, child pug scoring is what we do with, there is an online calculator which is easily available. However, recently I have also started doing the LB score because that actually predicts the survival much better than the child pug. Basically, it's to decide in a patient who has an advanced child pug score whether the LB score is also high, so it becomes easy for us to explain the prognosis of the patient to the relatives.
Yeah, right.
BCLC staging is something which we all follow currently because in an early situation or even in a multifocal disease, there may be role for loco-regional therapies which are readily available nowadays.
Yeah, rightly said. I think so that what this everybody is following. Dr. Shailesh, what is your opinion on this? Dr. Shailesh is there? Okay, so get into that. Dr. Anup, just you can comment on that. What is the percentage of these patient segregation in your clinical practice, and what score you're routinely following in clinical practice?
So what I see is exactly inverse of this. I see more of advanced cases, maybe 20 to 25% of early, 45% of CTPB, and then most of them are advanced. Unfortunately, the referral pattern or the detection over here is more in C and B class. What I use routinely CTP. Most of these are already metastatic. So most BCLC early are dealt with an onco surgeon or IR people. So I use CTP mostly. Um, Other than that, this is the main difference between I think my practice and such practice in Mumbai, that we find most of the reference in very late stages.
Okay, yeah. I think so. It's a similar kind of presentation in each of us because most of the patients are coming from the gastroenterology department. Here we have a surgical oncologist. So I just want to ask a question with Dr. Nagesh that what criteria or parameter do you follow to look for the patient is transplant eligible or not?
The Dr. Nagesh is having some technical issues here.
Okay. So whenever he will join, we'll just come back for this question to him. So depending on this presentations, then what is the most common underlying etiology of hepatocellular carcinoma you see in your clinical practice? As we see this, the risk etiology factors are changing nowadays. So there is a certainly difference. So Dr. Shyamji, if you're available, then what is
Yeah,
your
I am
routine
available.
finding? Hi, Dr. Shyam. And Dr.
Yeah,
Sandeep, what are the most common underlying etiological factors?
yeah. Particular in my setup, the most common etiology is basically alcoholic cirrhosis, then hepatitis. But if we see the overall picture, it's to the non-alcoholic to the from alcoholic to non-alcoholic. But in my practice, we are seeing most commonly in alcoholic, then hepatitis,
Okay.
viral.
Commonly, you feel that the patients are coming mostly of alcoholic.
Yeah.
Okay. So Dr. Sandeep, and what is your
Yeah, usually in practice in Nashik, I see almost equal of hepatitis B and alcoholic. Slightly more towards the alcoholic, but hepatitis B is still a major chunk compared to the others.
Okay, okay. So I think so as of today, most of us are having patients with of alcoholic disease, but that what the data says that this is a study from the Indian parameters where they have looked for some etiological fractions. What they have found, the most common etiological factor nowadays is NAFLD. Now it is termed as mass LD, followed by viral etiological factors. So we see why it has increasing because of the metabolic causes like NFLD, NASH, obesity. It directly disturb the or cause the cirrhotic changes or immunosuppression leads to the hepatocellular carcinoma.
Yeah, this is actually quite common, Dr. Srivastava, which we see here is that these patients behave also very aggressively. They
Yes.
present with multifocal disease. They present with extrahepatic metastasis also very fast. And generally, we've seen that they have very poor prognosis in
Mm.
terms of response to therapy, be it whatever that we use as first line or second line.
Yeah, yes, so truly said, Dr. Advait. That is what I found in my clinical practice. The patient of mass LD or NFLD, they are coming with a big lesion, extrahepatic metastatic upfront, and the responses are not so good as we compare the patient of viral lesions or with the cirrhosis. So this is the depiction of 1200 cases where they have found the NFLD slightly on the higher with the alcoholic causes 44% versus 40%. Rest of the 7 and 4% of hepatitis B and C. So, as already we have discussed regarding what kind of score we are using, both I think so, LB, BCL, and child pug score we are using in our clinical practice. This is the BCLC updated 2022 classification, what we routinely use to determine what kind of treatment and what is the stage and what kind of treatment is required. So today we are discussing about the advanced stages like C, where the extensive disease, the systemic treatment, and these are the various options based on this. We'll discuss. So, if we see that what is Dr. Advait and if Dr. Shailesh is there, what is your preferred choice of treatment for first line unresectable SCC in your current practice? As of today, patient is coming with Rolls Royce, no financial issues, so, what is your thought on this and why?
So we clearly had initially best supportive care as therapy, and then came sorafenib and lenvatinib. And after a long hiatus of about 10, 11 years, there was the first data which was presented for atezolizumab.
Yes.
After that, what has happened is you have multiple different options. You have durva-tremi. Durva-tremi is one of the options. You have the Nivo EP data also now, which is also can be used as first line. And you do also have toripalimab plus bevacizumab as another option, which is although based on a phase 2 data, but both the drugs are available in our country. Single agent immunotherapy, I'm not too much in favor of because I don't think it really works. Between all of these, when you look at the results of the dual agents, the Tremi Durva as well as Atezolizumab, you see that ultimately the PFS curves are almost the same.
Yes.
In terms of patient selection, and basically how many doses or where the patient is staying, when we look at the Durva Tremi, it is once in 4 weeks, so it's just 12 doses in a year. When we look at the other agents with Atezolizumab, it is every 3 weekly, so it becomes 18 doses in a year. So if patients are staying far off, want to come every 4 weekly, Durva-Tremi would be my choice, because that's just the first cycle where dual agents are used, and subsequently it's only single agent Durva. In terms of overall cost, the 4 weekly regimen, if you look at total cost of even 1 year of therapy, the total cost is actually lesser than giving the 18 doses. So, however, said that, where would I prefer Tremi Durva over the Atezolizumab is for a patient where bleeding risk is higher, patient having esophageal varices, patient having a gastric ulcer, which are very common in patients where HCC coexists with portal hypertension. I would always do a upfront upper GI endoscopy and prophylactic banding, or even give anti-H. pylori therapy if there is a gastric or a duodenal ulcer that we detect. And in these group of patients, rather than waiting for 3 to 4 weeks and reassessing them after 6 weeks for another endoscopy, I would start with Durva-Tremi directly as a safe regimen where there is no risk of bleeding, especially the one which happens post-bevacizumab.
Yeah, rightly. You have just described it very clearly then what kind of scenario and what kind of therapy you are using. Definitely, one most important aspect you have discussed about the cost. If we are treating the patient in a corporate hospital, the cost of Tremeli Durva is lesser as compared to the AB regimen. Dr. Sham, you have a different setup. So, what is your preference of choice
Yeah.
for upfront?
Basically, yeah,
Upfront
in our government setup, we are using normally lenvatinib or particular those in viral load patient. We still use sorafenib, but it's very toxic as compared to the lenvatinib. But some of the panel patient we also used atezolizumab plus bevacizumab.
Okay. So have you have any experience of Tremalidrova in your practice?
No, no, no.
Okay. So that this is the similar NCCN recommendation as Dr. Advait is rightly enlightened, that the Atezolizumab is a category 1, Tremalidrova is again category 1. Nivo is coming up, but still pending for some approvals. So that's why it is not in the category 1. Durva mono can be used, and TKI is definitely having an options of choice. So after using all these therapies, or so what is the average overall survival you observe in your clinical practice in advanced SCC? So if I ask Dr. Anup and Dr. Sandeep, what is your that assessment, that how long patients are surviving?
Sandeep, you want to take?
Uh, okay. See, it's sir, again depends upon the disease at presentations. So if it is child took A or early, so we are seeing almost like patient surviving 18 to 24 months. But the patients present in later stages like child took C in all things, even in our settings, hardly able to give a immuno. So Lenva we are giving and seeing less than 12 months. So it's all depend upon the presentation. So child spook and others.
They're discussing about the advanced. So as you're saying that 8 to 10 months is your usual survival, what you see in your practice for advanced stages of SCC. Dr. Anup,
Yes.
what is your that assessment?
So if I'm using lenvatinib, mostly it is around 12 to 15 months. If I'm like trying to sequence with atezolizumab followed by then maybe some patients 18 to 24 months. Again, what Sandeep had told, all those taking into those things in account, this is what I have found.
Okay, so you said that 18 to 24 months, it's a quite.
And the higher side, yeah, on the higher side, if I sequence.
Are you convinced that 18, 24 months?
Yes. Even I have some 1 or 2 patients which are beyond 36 months now, but they are very like exception cases.
Yeah, awesome. So, what in our clinical practice or my clinical practice, I usually see this 15 to 18 months or sometimes 20 months is the usual survival. And whenever in some of patient of AB, it crosses just 20 months, not like, more than 2 years survival. So this is the data came from the SHARP study. That was the first study which looked into the which where we have found the overall survival benefit as compared to the placebo with the 3 months OS benefit, and it did work well in SCV related cirrhotic patients. Then the reflect came where the Lenva was compared with the sorafenib, and it was non-inferior. Similar kind of OS difference was there with the Lenva as compared to the Sora. So again, but less toxic as compared to the sorafenib, because 400 BD was quite difficult to tolerate to the patients. Then after the TKIs, IOs came into the picture along with VEGF inhibitors. So IM Brave was the first study which evaluated the atezolizumab versus sorafenib in first line advanced unresectable hepatocellular carcinoma. And they have stratified the patient based on performance status, region, macrovascular invasion, extrahepatic spread, and baseline alpha fetoprotein that was less than 400, more than 400. And randomized in 2:1 fashion, atezo 1200 3 weekly, bevacizumab 15 milligram per kg 3 weekly with sorafenib 400 BD. The OS was the primary endpoint. Here we can see with the graphs are clearly showing that atezolizumab combination has a significant better overall survival and PFS benefit as compared to the sorafenib. It did work well in all except in non-viral etiological factors. So all other factors are in favor of atezolizumab. So Dr. Advait, it is a similar experience of with the AB regimen in your clinical practice, and is anti-VEGF therapies are acceptable or tolerable as you discussed the toxicity, the bleeding, hypertension, and proteinuria with the bevacizumab and treatment and immune related adverse event. So what is your experience with this?
So AB regimen has been quite a well-tolerated regimen. I think when we started using bevacizumab for HCC, we were already using this for ovarian carcinoma. We had already done and stopped using this for lung and for breast. So the learning curve for using this drug or monitoring it at differential doses, 10 milligram, 15 milligram per kg, it was not much of a problem. However, the main concern here is the hypertension, because we do see that almost 20% patients do get grade 3 hypertension. About 12 to 15% patients do get grade 3 proteinuria also. And that is something which we need to monitor. The bleeding risk is not very problematic. However, for the patients who bleed, there have been data to look at reducing the dose of bevacizumab from 15 to 10 mics and then re-challenging it after the bleeding episode subsides. If there is a subsequent bleeding episode, then the bevacizumab needs to be taken off.
Yeah,
So that is what we do in clinical practice. So the hypertension and proteinuria needs to be monitored, and we do need to bring in ACE inhibitors or ARBs in case that happens to manage the proteinuria as well as the hypertension.
Yeah, rightly said. These are the routine complication, which is mostly happening because of the bevacizumab, but monitoring is important. And the
So
intermittent
immune-related adverse events can be catastrophic at times. So I've had a couple of patients who developed an acute myasthenic crisis post 7, 8 doses of immunotherapy. In fact, required ventilatory support. One actually succumbed during this entire episode of myasthenic crisis. So these are something which we need to be really wary of. And as we tell our students also who are training with us, that if patient is on any IO, make sure that you actually rule out that this is a immune-related adverse event before labeling it anything else.
Yeah, yeah, rightly said that we have to be very vigilant while we are using combination of immune plus VEGF inhibitors, along with or double IO or any kind of IO therapies, because it's gradually creep in and become as a severe symptomatic to the patients. So that is very important. We have to keep in mind. This rightly said this Bev is having a most common side effect like hypertension and proteinuria and sometimes bleeding, which we usually face in our clinical practice as well. So, Dr. Shyamji Rawat, after this discussion, that do you think that we need to explore a different pathway other than anti-VEGF to combat SCC?
Yeah, definitely. Because there is a limited survival data, so we should explore the newer therapy like Prame, Durvalumab, and different.
Yeah, definitely that, because as we are not satisfied with this very grim survival of hepatocellular carcinoma in spite of all the evolution and development, so definitely we need to go and look for another option. So there is a after the anti-VEGF and immunotherapy combination, There was a phase 3 study, that was Himalaya, which was a randomized open label multi-center study where they have added the tremelimumab 2 IOs together as first line therapy in patient with unresectable hepatocellular carcinoma and compared with the sorafenib. That was the double ion, and that was a 4-arm randomized study where they have taken one stride arm, that is durvalumab 1500 milligram 4 weekly, tremelimumab 300 milligram single dose. Arm B was durvalumab monotherapy 4 weekly 1500 milligram, and Arm C was sorafenib 400 milligram BID. Arm 4 was not analyzed later on, so 3 arm were compared. The primary endpoint was overall survival. This is the regimen of stride that in durvalumab 1500 milligram and 300 milligram of tremelimumab, one dose, and 1500 milligram continuously 4 weekly. Durvalumab monotherapy 1500 milligram 4 weekly, and this sorafenib 400 milligram BID. That was the regimens to be compared. So, Dr. Anup and Dr. Sandeep, what is your thoughts that in this study they have taken only the single dose of tremelimumab? So, do you think so? The single priming of tremelimumab is sufficient, or should be something else?
Actually, I'm not aware about the preclinical part or the translational research behind why only single dose of tremelimumab has been given. But what reasonably I could conclude is that only one dose might be enough to overcome the resistance to the CPLA pathway, and giving another like repeated cycles might increase the toxicity. So there might be some receptor occupancy studies or the T-half studies of that, and that's why they are only given one cycle. It just educated guess from my side.
Yeah. Dr. Sandeep, what is your thought that why they have taken only the one dose of tremelimumab?
Uh, I also not aware about this study fully. So,
Dr.
so yeah, what Anup says that may be a look like reason, but yeah, frankly, not use this drug or not aware of this pre their clinical.
Like to comment on this?
Yeah, so Dr. Srivastava, if I can just comment on that. Hello.
Yes.
Yeah. So tremelimumab was brought in to look at how it can decrease the resistance to durvalumab. Now, when you look at this study, there is also another interesting study which they use durva-tremi metastatic non-small cell lung cancer,
Yes.
in which they had given tremi for 4 cycles and then a fifth dose every 4 weekly or something like that. That was a phase 2 study that didn't see the light of the day because anyway that study turned out to be negative. But even in this study with the 4 arms there, they had used 2 doses versus multiple doses, and mainly the toxicity was much higher when multiple doses were used. Secondly, this low dose or low multiple dose strategy was actually found to be less effective at activating the T cells as compared to the single large loading dose. And that's the reason why they continued with the single dose while the other 2 arms actually closed down during the trial. So that's the reason why you would use a single loading dose to activate the T cells and just leave it at that rather than giving smaller doses in which you just add on to the toxicity but not on the benefit.
Dr. Shrivastava, just to add on, absolutely correct, Adwaita. The intention of this study was just to activate the single dose. Tremi will activate T cells, and then dual low dose maintenance was not very efficacious. That's why they continued with single IO as the maintenance, that is Durva. However, Tremi is mainly for T cell activation. You're absolutely right.
Rightly said, the T cell activation increase the immune response, decrease the toxicity. That's why probably they have not gone for this. And continuation of dual IO was not efficacious as compared to the single. That was the reason behind that. That rightly said by Dr. Bhushan and Dr. Advait. That so it is the demographics and baseline characteristic of this study that the median age was 65 year or 64 years almost. The region wise Asia and rest of the world was taken. Viral etiology and non-viral etiology patients were there. Good ECOG performance status 0 and 1 was taken. BCLC-B. There are some patients of BCLC-B and most of the 80% patients of BCLC-C. ALBI score and Child-Pugh score they have used. Uh, mm, MVI extrahepatic spread in PDL1 also taken, AFP 400 milligram, more than 400 milligram, but stratified as a feature. So after this combination of therapy, what we have found is for subsequent therapy or second line options. So almost in all the three arms, almost any therapy option, almost 40 to 42% patients were gone for this any therapy options. So therapies are better, and depending on the further response will decide. This is the stride demonstrating a statistically significant improvement in median overall survival versus sorafenib. So here we can see at 3 years it is almost 10% benefit is with the stride arm as compared to the sorafenib, and the median OS was 16.4 versus 13.8 with a 0.78 of hazards, which means that 22% benefit in the death rate, and there was a 10% at the survival benefit. So this was the data for 3 years, and recently what I checked, just 5-year OS data is also came out that it is again showing 20% benefit is there in these patients. So 1 out of 5 patients are surviving at 5 years. So that is a quite significant. So any thought on 3-year OS data? 1 out of 3 patients are alive with stride at 3 years. Dr. Sham, Dr. Anup, what is your thought?
Depend upon the presentation of the patient in our institute. So usually in our institute, patient present with a poor condition and financially is also poor or health-wise also poor, not taking supportive care. So I think particular in our setup, this is um, uh, quite not achievable.
By just checking this data, you would like to prone to use this combination if patient can afford and patient is fit to take this regimen. Dr.
Yeah,
Anup,
definitely. But if compared with the sorafenib also the 2% survived as compared to 3% survived with this arm.
and Dr. Anup.
I agree with sir. I concur with sir. Same thing. If patient is able to afford, I would definitely like to use stride regimen. What we can use Len or Sora at later point of time also. Obviously, the sequencing data is not there, but it's an interesting study to be there. And then the issue with the Bevacizumab and then the recurrent portal hypertension and repeated EV banding, that is also circumvented when we use this regimen.
Yeah, that's true. By looking at this data and by the out of this 5-year OS data, there is a very good regimen to be used. So that stride is one interesting point in the forest plot that it has worked in the non-viral etiology as well, whereas the AB regimen did not. So that was a plus point with this regimen. Patient is suitable, patient can afford, we can consider to go ahead with the double IO combination. If we see the overall and duration of overall response and duration of response, which was comparatively higher with stride regimen as compared to sorafenib. If ORR, if we see the 70-20 versus 5.1, even Durva mono was non-inferior than sorafenib, and it was higher, more than 3 times higher overall response rate. And similarly, in the median duration of response, the stride was having the higher median duration of response. If we see the toxicity wise, already we have seen that the AV regimen and sorafenib. Here we are comparing with the stride regimen. So immune related adverse event was there definitely, but if we see the grade 3-4 immune related adverse event, it is only on 12.6% of patients as compared to the durva mono, that was half of that, and sorafenib it is almost 1/6 of the stride regimen, which were quite comfortably we can manage because now we are having a hands-on experience of managing the immune related adverse events, and these are the common treatment related adverse event with the stride regimen: rash, pruritus, diarrhea, and all the itis as we have seen with this regimen. Mainly what I have seen in my clinical practice, that was colitis with this tremali durva combination. if we see the treatment-related hepatic and hemorrhagic side effects, so not much in comparison to this sorafenib. So finally, I just please everybody just a single liner comment. What are your thoughts on safety profile of Himalayan data? And would you change your SOC treatment for unresectable SCC based on Himalayan data? To start with Dr. Advait. Yeah.
So I think, Dr. Srivastava, this is a very, very interesting way of managing advanced HCC. It does bring about another option for our patients, which is quite well tolerated, where you're using one drug in a single dose and continuing every 4 weekly maintenance with an immunotherapy. So in terms of tolerance, it is possibly better tolerated than AB regimen. That is what my personal experience of using this is. However, I have used this in patients where essentially bleeding tendency has been higher, or if the liver function derangement has been more, in which I'm actually worried about using bevacizumab as an anti-VEGF therapy. It also helps me to decide that irrespective of the etiology of the HCC, I can use this, because we've seen the AB data works better for the viral etiology as compared to the non-viral etiology, and much lesser rates of hemorrhage and other complications as compared to bevacizumab. Because that 15 milligram per kg bevacizumab, we all know not many patients do tolerate that dose at a sustained every 3 weekly schedule. Most of the times we will need to reduce the dose. So it's another regimen which we can use and we can offer our patients. And I think currently, in terms of immunotherapy and combination with another agent, we have about 4 options which are available. And I think it's a good time for patients where there are multiple options available from which we can select out, where most of these options are giving similar kind of ultimate PFS result.
Yeah, rightly, sir. Rightly said. Yes, Dr. Anup.
Sir, I agree with what Adwaita Gore sir has said. Seems to be very good regimen. Once a month, patient has to come. A very short duration of infusion, only first cycle double drug, and then only once in a month treatment. I think this is the first regimen to show and always benefit at end of 3 years. And obviously, there is always concern of bleeding and complications of bevacizumab. And if you're able to avoid that drug, that is better. Financially also, it seems to make sense, because 15 milligram per kg using every 21 days, that is also that also factors in when we are calculating the cost of this. And it gives a good option for us to use this.
Dr. Sham.
Yes, sir. Rightly said, Dr. Advait. The 4 weekly drug and usually we give 2 drugs in one setting, then single drug is whole year. So I think this is a quite good setup, and with less time to visit the hospital, and with good quality of life and good comorbid condition.
Dr. Sandeep.
Yeah, definitely in affordable patients, we can consider we'll have another armamentarium in our things in SCC patients.
Yeah, rightly said that. I also concur with all the panelists that this is a newer regimen which can be tried in those patients who are having, some bleeding tendencies, some nephrotic like conditions, and even if we compare with the cost wise, it is cheaper as compared to the Atizo web, because web dose is quite high and Atizo also costly. So for any setup where the corporate setups, this combination is cheaper as compared to the AB regimen. And as we have rightly seen, the benefits are there, viral, non-viral, both the etiology is working. So it is not a problem that we are just looking at that patient is of having viral or non-viral, then we are deciding. And bleeding tendencies are not there, proteinuria is not there, and immune related adverse event definitely we are not so challenging nowadays. We can manage comfortably except in 1 or 2 cases. So finally, with all the discussions, that on my conclusion slide is that hepatocellular carcinoma is one of the topmost common cancer affecting Indians. There is a shift from viral to non-viral etiology responsible for more SCC cases in current era. Atezolizumab has been new SOC in advanced SCC. The steroid regimen improved OS versus sorafenib and demonstrated an unprecedented 3-year OS rate. The steroid seems to benefit across all subgroups, including non-viral etiology patient population. The steroid was well tolerated with low rate of discontinuation and GI hemorrhage. Durva monotherapy was also non-inferior to sorafenib for OS with improved safety profile. So steroid and Durva monotherapy represent a potentially new treatment option for patient with unresectable hepatocellular carcinoma. And so with this, I rest my discussion over there. Thank you, everyone. Thank you, all my panelists. Thank you, Dr. Bhushan. And if anybody wants to make a comment, final comment, we just are open.
So we'll be taking question at the last, Dr. Shrivastava, if there are any. So if any question, you can type in the chat box. We'll take it later. So thank you, Dr. Shrivastava, for finishing in time. Okay. So we'll be moving to our next topic of discussion. That is the HR positive HER2 low metastatic breast cancer. And the moderator for this panel is Dr. Shailesh Bondarde. Dr. Bondarde doesn't need any introduction. He's the senior most oncologist from Nasik, and he's currently director and chief consultant medical oncologist at Apex Wellness Hospital. Over to you, sir.
Thank you, Dr. Bhushan and AstraZeneca for giving me this opportunity. Can I share my slides?
Yeah.
Can I do it now? It's still Bhushan's.
Yes, sir.
One second.
Yeah, can you help?
Is that okay?
No,
Sir,
we
if
cannot.
presentation, sir?
Yeah. Can you see the slide?
No,
No.
sir.
I-
Sir, I'll just stop your screen share. Sir, if you can now click on share screen and then click on your presentation.
You want me to stop share screen?
Sir, I've already stopped your share screen, sir.
Okay, you have. Okay.
Yes, sir.
Now this is my window. Share. Participants can now see your screen. Okay, now is it visible?
No, no, it is not visible.
No, sir. Sir, we'll share the slides from our end, sir.
Please, yeah, I think that's better.
Yes, sir.
So I have my panelists. Most of my are my colleagues from Nasik and Dr. Shyamji from Jabalpur.
Sophia?
Hello. So the screen is visible?
No. Yes, I can see it now.
It is visible.
Yeah. Can you go to the next slide? Can you make it a slide C, because I can't see the bottom of the slide.
Sir, are you able to see the screen now, sir?
I am able to see, but I'm not able to see the last couple of slides of the, now it's okay, fine. I think that's from my end,
Okay.
probably. Okay. So let's start the discussion. This is basically a panel discussion on HR positive, HER2 low breast cancers. And this is the story of a lady, a 50-year-old postmenopausal female with a right breast lump, biopsy done, IDC grade 2, ER positive, PR positive, HER2 IHC 0. T2, 5 centimeters, N0, M0, adjuvant docetaxel cyclophosphamide into 4 cycles, sorry, new adjuvant, followed by surgery, followed by radiotherapy, and then followed by adjuvant letrozole. Germline panel was negative, lost follow-up for 5 years. Next slide. And the patient comes with a severe backache. MRI suggests bone mets. Next one. And this is what the PET picture is. Pleural-based soft tissue mass, large pleural-based mass, which you can see on the right side. 5 by 4 by 3.6 centimeters. Pleural-based multiple nodules. Mediastinal nodes. You can make out a large hepatic lesion in the middle slide. And multiple small hepatic lesions can be seen in the slide below. And obviously you have multiple bone mets. Bhushan, do you feel that this looks like HR positive, HER2 negative metastasis? Or clinically you feel like this doesn't fit clinically into the typical HR positive, HER2 negative, and you are...
Yeah, generally not fitting into the very typical HR positive, because generally they have a bone predilection and such a florid met generally do not happen usually. So really need to see the hormone status now for this patient.
Yeah, so you would like to reevaluate again with the biopsy. And if this patient only has bone mets, then are you comfortable continuing the same,
Yes, probably yes, because getting bone biopsy, if there is no soft tissue component. Now this patient has some soft tissue component in clavicle, but if it is not there, then it is very difficult, and we probably believe in the first report because it's typical bone related meds like in hormone positive. So in that case, probably no biopsy, but this patient definitely biopsy.
Next slide. So Dr. Mukesh, do you agree with what Dr. Bhushan says, or do you have some other thoughts? Dr. Lovin?
Yes, sir, I agree with Dr. Bhushan, sir. A rebiopsy, and since it is a florid meds, biopsy would be better.
So this patient has also undergone a biopsy from the liver, and the ER/PR is positive. HER2 now is 1+, FISH negative, with a high Ki67, and obviously confirmation that it is primary from the breast. Next. Dr. Sandeep, do you typically rebiopsy a patient in this setting, or do you advise a rebiopsy for all the patients who develop metastasis, or is it case-to-case basis?
So it's again depend upon the what is a DFI, whether patient is continued treatment or not, because this patient has discontinued treatment, lost follow-up for 5 years. So we actually not knowing that it is just like the disease biology of not behaving as a hormone positive HER2 negative, or it is a changing of hormone therapy. So basically, if patients progress within the short DFI, then we can consider not to. But if the long DFI or a regular treatment, then we should consider rebiopsy. So sort of like a case-to-case basis.
Dr. Shyamji, if the same patient is HER2 positive to begin with, it is +3. So are you inclined towards doing a biopsy? Because anyway, if it is +3 And now if it comes HER2 2+, are you going to plan, and FISH negative, are you not going to treat these patients with HER2 directed therapy? Forget about whether it is a TDX or any other thing, but just for discussion sake, any HER2 directed therapy, if the patient is already HER2 3+.
Right, sir. First, we do the repeat biopsy. First, we need to confirm it might be a second malignancy or second primary because it's a long gap after 5 years. So, if the parties, can you again ask this question?
So this patient is, for example, patient is HER2 3+, and
Right.
now the report comes as HER2 2+ and FISH negative. So will we treat these patients with a HER2 directed therapy, or will we not treat this patient with HER2 directed therapy?
Right now, we have the good option with the TDXT.
Taking into consideration that we are not talking about TDXT.
Yes, sir. If we don't have right now in the area of clear back, we just treat patient as the ER positive and HER2 negative.
Dr. Lovin, your take on this?
Sir, even if the first initial was HER2 3+, I'll consider this time also as a HER2 positive. It will be probably because of dynamic expression of the HER2, especially in metastatic site. So some of the clones might be expressing HER2, and so I will keep HER2 and target therapy as one of the option in the treatment plan.
Yeah, it is sometimes, I mean, if the patient is 3+ and then now becomes 2+, it's difficult to ignore this first report. And we won't have such data also really to, discuss whether treating and non-treating, will it make a difference? What about rechecking the HER2 on the earlier blocks? Bhushan, do you take this call? It might be difficult for you to tell the pathologist to relook at the diagnosis when she has made it. I am putting all words very specific.
So generally, I don't do it because anything, whatever has happened. It will give us the more trouble. So generally, I would prefer doing it in newer block only. But for academic purpose, probably recheck it. But I generally don't do it in practice like this.
Okay, next slide. So this is what happens with the HER2. I mean, it can go from one place to other, and there are studies which has shown that in a primary and at the time of metastasis, the HER2 can change, and the dynamics are such that it can increase up to 44% and it can reduce up to 22%. So it can happen that the patient which is HER2 0 can now become HER2 1+ or 2+ or FISH negative, and even 3+. I mean, some patients, though the number is less, but you can have the tumor, the report coming as HER2 3+. And it's also that a few of the patients which are patients which are HER2 low can get converted into HER2 0. So I think it is important for us to rebiopsy and try to find, because now we have options where HER2 1 is treated and 2+ with FISH negative can be treated with a HER2 directed therapy. So all the patients which are HER2 0 or HER2 negative, when we talk earlier, we used to talk HER2 negative means anything from 0, 1, 2+ and FISH or ISH negative. Now I think the dynamics and the reporting has also changed. Next slide. So it can happen that the patients are HER2 negative and now become HER2 positive in maybe low or ultra low. So the HER2 low is worth looking at, even if the patient is HR positive or HR negative. So Lovin, do you agree with this, that there can be discordance in testing and changing from the primary to metastasis? Discordance, I would like to say, maybe between the two labs, that's a different story. So do you retest it again, or do you believe that the local testing which is done in HER2 testing done is okay, or you send it to some other lab and or you confirm all of them with fish?
So sir, HER2 3+, usually I don't think so. There would be so many discordance if it is 3+. 2+, probably if there is strong clinically also, patient is not say in this same case, if the patient was only hormone positive and HER2 0, and clinically the patient had a very early relapse, a very florid relapse, then that time I'll recheck HER2 from another lab. But in 3+, I would not. 2+ also, which are fish positive, definitely no need to check from other lab.
Dr. Sandeep?
Yes, sir. I agree with Dr. Loin. If it is a frank 3+, no need to check. But it is actually really difficult practically to check each and every patient with another lab with this one. Yeah, we can check it IC with the fish, because sometimes we see fish negative also shows. IC negative also, or IC 1+ also shows fish positivity. But IC with IC checking with each lab with different lab, it's practically sometimes not possible. Only when we have clinical suspicions, we should like I am checking when there is a clinical suspicion.
Dr. Mukesh, do you do that? All the reports which are done outside, do you recheck it in your lab
No,
just
sir.
to see the discordance? Because
I agree
sometimes
with Dr. Lohin sir and Dr. Sandeep sir. I generally don't recheck, sir. If it is HER2 3+, then definitely I go with HER2 directed therapies without checking.
Okay. Next slide, please. So this is what happened in Destiny 4 when they had a central lab. 78% of the samples designated as HER2 low by the local lab were confirmed as HER2 low at the central lab. And of the 22 discordant samples, 88 were centrally scored IHC 0. The low were scored as 0. And 12% were upscored. In fact, they were either IHC 3+ or IHC 2+ with fish or ish positive. So discordance can happen, but the treatment can change altogether. And the response rate of the treatment can change altogether. Now, 22% is a big number, I feel. So it is worth sometimes, if clinically the scenario doesn't fit into what you expect clinically, then it's worth having a second look. It is possible because in a trial it is possible because you have one lab and you have the best lab in the world doing this samples testing. So, but in clinical practice, sometimes it can be difficult. Next. So there are a lot of factors which depend, which actually interferes with the reporting of HER2. And I think one of the important, what I always, when I talk to pathologists, is the sample handling. The 10% formalin, what is required, I think it's always a question, because once I had talked in a national forum, and the pathologist says it's all depends on the formalin. So one of the leading breast oncologist had asked, where do you get this formalin? So it can happen that there are various factors which are important when you are interpreting the report, and every step matters. Next slide, please. So, Dr. Bhushan, I mean, as we all are talking now, especially after the TDX came into the picture, a lot about HER2 low and HER2 overexpression and ultra low and so on and so forth. So, are these definitions, do they matter us for planning the treatment? Next slide, please. Yes, Bhushan.
Yeah, definitely. So as you rightly pointed out, definition keeps on changing. So earlier we used to just say that whether it is positive or negative, and now even the reporting it changes from the pathologist because of this ultra low HER2 expression or a positive expression. but it really matters. And coming back to your question of whether I test it, repeat test it or not, I generally do it first time only with the reputed lab. So generally that wherever I'm more comfortable with. But as everybody pointed out, clinically, if it is not matching, like this patient is hormone positive, if it is not matching your clinical judgment, I would really request all patients to be really look for HER2. Don't believe on your first report when the history and the clinical scenario doesn't match. You get it done from a reputed lab. Sometimes you get surprises.
Dr. Mukesh?
Yes, sir. I agree with Dr. Bhushan, sir. I generally do in the reputed lab only. But if there is any discordance between the clinical scenario and the reports, then I will definitely go with the rechecking.
Next slide, please. So that's $1 million question. I feel, now you have a biopsy, you have a previous biopsy, like we discussed a scenario where the patient's HER2 is 3+ to start with, and then it becomes either 1+ or 2+ with FISH or ISH negative. What is to be done? Next slide. Dr. Sham, your take on this?
Right, sir.
We should do the biopsy of the metastatic lesion because there is a lot of changes from HER2 low to HER2 positive and HER2 positive to HER2 negative, and also in the hormonal status.
Dr. Sandeep?
Yes, sir. We have to re-biopsy from metastatic lesion, but your questions whether to treat on initial or re-biopsy, it's again depend upon if definitely with the re-biopsy samples we have to go, but we cannot ignore if it is a fish positive or the ISC3 positive in initial samples, then we cannot ignore that one. Then in that case, we have to consider clinical scenario also. If the re-biopsy shows it is low or let's say frankly negative but low, and the clinically it's fitting in HER2 related kind of metastasis.
So, I mean, 87% of the expert did opine on this, and they say that anything which is higher in either of the biopsies should be taken as positive. For example, if the patient is HER2 3+ to begin with and becomes 2+ or 1+, then I think the one report which is positive should be taken regardless of the timing, whether it is in the metastasis or at the primary. Next slide, please. So that's about the Destiny Breast 4, where our patient is likely to fit in. The study included patients with documented breast cancer, metastatic unresectable with low HER2 expression, which was defined as IHC 1+ or 2+ with ISH negative, and should have been treated with at least 1 to 2 lines of chemotherapy adjuvant in the metastatic setting. Adjuvant where the DFS is very low can be taken as one line of treatment. Never treated with any HER2 directed therapy on prior pathology testing, whether it was IHC or was historically HR HER2 IHC 0 IHC negative for HER2. Never previously treated with anti-HER2 therapy. Exclusion criteria was the patient should be able to take the drugs which are the options in this study, which included the Enhertu and the physician's choice, which was in the form of gemcitabine, taxanes, eribulin, and capecitabine. Should not have any evidence of or history of ILD in the past, because Enhertu is known to cause this toxicity. Next slide, please. So this is our lady. She has now developed metastasis. Next slide, please. And because she is HR positive, she was put on CDK4/6 plus fulvestrant, probably because she was a refractory case. On treatment, she has relapsed. Next slide. She progressed after 8 months and started on capecitabine, progressed with newer bone lesions within next 3 months. Next slide, please. So the next line of treatment, Advaita is here. Okay, no problem. Dr. Mukesh, next slide.
Yes, sir. I will check PIK3CA mutation also in this case.
Correct, perfect. So PIK3 mutation should be done, and we have an options of treating with alpelisib and the newer PIK3 inhibitors also coming up in inavolisib, I think probably. So there are few drugs which are available where uh, PIK3 inhibitors can be tried if the patient has a PIK3 mutation. What about TDX as per the Destiny 4? Now you have an option of using TDXT for the patients who have progressed on 1 or 2 lines of treatment, even if the patient is HR positive and treated with hormone therapy. So this is the Destiny 4 study where the patients with HER2 low, unresectable and metastatic breast cancer, which were treated with 1 to 2 lines of prior chemotherapy in a metastatic setting, HR positive disease, considered endocrine refractory, are eligible. Later amendment was done to also include patients with HR negative. So there were few patients, I think 60 number, the number was 60 probably, number of patients which was included in this study, which were HR negative and HER2 low. The primary endpoint was PFS by the blinded independent central review for HR positive. Then for all patients, OS and PFS. And the secondary endpoint was PFS by investigator, overall response rate, duration of response, and safety. Next slide, please. So that is the demographics. You can see that HER2 low 1+ were around 60%, and 2+ with ISH negative was around 40% in both the arms, and also in HR positive and HR negative patients. Around 5 to 6% had brain metastasis, around 70% had liver metastasis. Next slide, please. Can you go back, please? If you look, okay, next slide, please. Sorry about that. So the lines of chemotherapy, you can see more than 3 lines of systemic therapy were around 66-67%. The chemotherapy were 60% were in one line of chemotherapy, and around 35 to 40% were 2 lines of chemotherapy. Next slide, please. CDK4/6 therapy was given to around 70% of the patients. Next slide. Now, if you look at the PFS for hormone receptor positive and all comers, you can make out that the PFS hazard ratio was around 0.5. So that's 50% of the patient benefited with this particular regimen, and the median PFS was 10.1 versus 5.4 of the treatment of choice by the physician. So that's almost double the PFS as compared to the standard of care, which is usually available in this situation. Similarly, in all comers also, you can make out that it's 5.1 versus 9.9, almost double PFS as compared to the standard of care. Next. If you look at the OS in the HR positive and all comers, the overall survival was 23.9 versus 17.5 months in the standard of care with the HR of 0.6. And in all comers, it was 23.4 months versus 16.8 months. In fact, it is usually said that, in the third line and onwards, to get an OS benefit is usually difficult. But you have an OS benefit here in these patients. So going ahead, I mean, this is one of a very good option as compared to standard of care when you are treating the patients which are refractory and you are treating them on third line onwards. Next. So you can see the waterfall plot, and you can make out that there is a good response in in many of the patients treated with Enhertu as compared to that of standard of care. Next slide, please. So there is another question which always comes up is what about sacituzumab govitecan? That is one which has been used in the triple negative patients. So which one should we use? Next slide. Dr. Sandeep, now these are two slides, two trials put uh, uh, next to each other, and we always write that bottom line cross trial comparison should be avoided owing to difference in patient population, study design, etc., etc. And we always talk about this, but that's fine. This is just to see the two graphs. The point here to make out is that the sacituzumab is being tried in third line beyond. Destiny, we have two line beyond. So does that make a difference? Plus the toxicity into the two different drugs are seen differently. I mean, do you agree with that, Dr. Sandeep? Do you have any comment other than this?
So you are talking about toxicity or the effectiveness and choice?
Efficacy and
Yes,
toxicity.
sir. Yeah, sir, I'll talk about efficacy first. Efficacy, sir, if you see TNBC, we have very less options, and then TNBC is like a, not a one disease entity, a different like a possible biologicals. So not despite that, except the PDL1 and if they are germline BRCA positive, apart from that one, we have very few options. So that's why the curves showing not much of the benefit with SG. But if you see in a HER2, we have good options and good drugs also. So and maybe they have a behaving, most of the tumors behave in a similar fashion, in a chunk, not as a TNBC, which has like a different fashions is behave. So maybe the efficacy looks better with the Destiny or in HER2 compared to SG. And toxicity wise, again, routinely what we see is in HER2, it's a interstitial lung disease, but that all we knows and we knows how to monitor that one. But SG actually are not used or even seen, so toxicity I cannot comment in SG.
But very well. I mean, that's a perfect explanation. But only thing is that this Tropic 2 study included HR positive patients. But we all know that this is third line and beyond, and this is obviously so. You do expect that the graph will be little worsen as compared to that of second line. The toxicity, I have not used sacituzumab. Anybody who has personally used it? Advaita, are you there? Okay. So it's supposed to be more toxic as compared to that of TDX. ILD is the main toxicity. Otherwise, myelosuppression, I have not seen much. One of my patient is taking 60-second cycle on TDX, and recently we have to support her with erythropoietin and romiplastin. But otherwise, I think it's quite well tolerated drug. Next slide. Yeah, good old days. I think when we never had any options, we always used to think whether we can continue the same treatment because the patient had responded for a long time. We did that with trastuzumab also when nothing was available. Even on progression, we used to continue trastuzumab. So when CDK4/6 came, HR positive, we didn't have PIK3 mutated drugs and so on and so forth. We used to think whether we can continue the same again. Lovin, your take on this? Next slide.
So with the available options, I don't think so. Means I will think about re-challenging with another CDK4/6. Especially the mechanism of action is not that different. Means isn't hardly any different between among the CDK4/6. So the other regarding your earlier question, there is some even phase one small trial data also that shows that sequencing the EDCs like after TDXD, some will respond to SG also. So it is not either or, it can be, we can sequence it accordingly. Okay, after TDXD, we can give SG. So that has also shown some response, but not that large magnitude.
Correct. So even with the continuing of CDK4/6, there are not many studies, and you can see there is a small difference. Most of the studies had a palbociclib to start with, and then they were either shifted to ribociclib, or some of them continued with palbociclib to see if the change of AI makes a difference. Not much, and I think none of us. Bhushan, do you practice this type today?
No, I generally don't do the sequencing of CDK inhibitor, but generally, as we change the hormonal management, if this patient could not afford TDXD, definitely everolimus and Afinitor would also be Afinitor and exemestane would be also a better choice for this patient. But I don't sequence CDK inhibitor.
Next slide. What about if the patient is BRCA positive, Dr. Shyamji?
Yeah, we can do sequencing with the BRCA if the patient is BRCA positive. After if the patient not able to tolerate the
Next slide,
TDXD,
please.
we can offer the olaparib.
Yeah. So these are the two studies very aptly told by Dr. Shyamji that if the patient is BRCA positive, there is a role of PARP inhibitors to be started in these patients. Next slide. Next slide, please. So $1 million question again, Bhushan, will doing an HER2 testing, will it matter in future? Or, now we have a drug which is effective for all the HER2, irrespective of whether it is, we are talking about low, but we are also talking about ultra low. Then some people say, but anyway, this is a very heterogeneous group of cells. Some cells will be definitely there, which will have some HER2 expression on some cells. So will it really matter to do HER2 testing at all?
It will definitely matter, sir, because prognostication change. We all know that HER2 3+ will have more results than HER2 2+ for that matter, as compared to HER2 1+. Maybe just positivity will help in deciding, but strength, the staining potential or the more positive, we will be expecting more results definitely. So I think it will stay, but I'm sure that it will get standardized over the period of time. I am sure that ISC for HER2 would also be standardized, what to label it, low, ultra low. Then I think it still matter how much it is.
So that's right. Even the way you quantify it, if in a breast tumor versus a stomach tumor, that also matters, and that also differs. So I think we will getting more clarifications of how to interpret those reports and use it in clinical practice. Dr. Lovin, maybe Dr. Mukesh, are you there?
Yes.
Dr. Mukesh, what about giving maintenance endocrine therapy if the TDX is stopped due to some toxicity? It looks valuable. I mean, looks a good option. And well, why not something like Patina regimen also? Why not add a CDK4/6 also to that? Though we are talking about this is the second line and third line onwards. So most of the patient must have received a CDK4/6 for sure. If not, maybe we can think of. Yeah, Dr. Mukesh, your take on this.
Yes, sir. In third line, sir, we can definitely think of adding endocrine therapy and also CDK4/6 inhibitor. If patient is not tolerating TDX, in patients where there is endocrine hormonal is the driver factor, in those cases that will work. That is what I feel.
Great. Next slide. So I think with that, I thank all my panelists for excellent discussion. Most of
Excuse
it.
me, sir. Can I ask one question?
Yes, Sandeep, please.
Sir, going back to your case, I think it is hypothetical case, but there are some caveats in that case. First thing is clinically T2N0M works strongly hormone positive. So why NACT? Second thing, if it is NACT given, what is the response to that after the NACT to surgical? Because that also shows if it is a strong hormone positive, sometimes we see that they doesn't respond well to the chemotherapy. So that also things has to be seen while thinking about the second line, next line, and all that things. So that is not the given. Maybe look like some hypothetical case, but they are not given. What is the response to the surgery? Like the response to the NACT. And if early, so then why surgery? Why not surgery upfront?
Yeah, that is point well taken. I mean, with NACT, you don't know even the nodal status. Today, we won't treat that same patients similarly. It can happen that with that tumor size of 5 centimeter and HR positive, HER2 negative, you might go for surgery first to know the nodal status also, because you might treat this patient with adjuvant CDK4/6 also, depending on the size of the tumor and the nodal status. So today it can be a different story. This is 2017. The case started in 2017, something like that. So I don't know. Your question is very valid. Why and what happened to the PAT-CR? Though we talk about more in triple negative and HER2 positive, but in HR positive, we know that we are less likely to get a PAT-CR. But your question is well taken.
Thank you, sir.
I think so we'll stop because thank you, Bondarde sir, for such nice case presentation. So we'll be moving to our next topic, and that is Pertuzumab in breast cancer, and it will be presented by Dr. Anup Toshniwal. Dr. Anup, everybody knows, he is the leading medical oncologist working in Chhatrapati Sambhajinagar. So over to you, Anup.
Sir, thank you first of all for that kind introduction. Um, just this is my slides. Are my slides visible?
Yes, Anup.
Yeah. So, just these are my disclaimer that this presentation is given to me by the sponsors. I am just presenting this, and the topic which is given to me is the dual HER2 blockage, changing the way of breast cancer management in India, and that is Pertuzumab in breast cancer. So, this is the data which was taken from National Cancer Registry Program in India. Here we can see that breast cancer is rising fast and is one of the most common cancers, as we all know. 2015 had 1.8 lakh cases. Then it increased to 2 lakh and then 2.23. And the projections are that every 8 to 10 years, the number of cases are going to double. So let's come to the area of interest of this topic. That is, what is the incidence of HER2 positivity? So approximately 20 to 25% of breast cancer patients have tumors that are HER2 positive. And let's have a glimpse of present and future landscape of HER2 breast cancer management in different settings, especially with dual HER2 blockage, where dual to HER2 blockage is the use is increasing. So first of all, in the neoadjuvant therapy setting, so generally, where we are considering neoadjuvant therapy in early breast cancers, there is a high tumor volume or lymph node positivity, high risk features like high grade, HER2 positivity, TNBC, or young age at diagnosis. And specifically in HER2 positive, when we are looking to use is tumors centimeter in 2 centimeter or more in diameter, or has a node positive disease, we generally try to give chemotherapy plus trastuzumab and pertuzumab. Now, as we all know, this is the pivotal neosphere study where chemo-naive women who were HER2 EVC with primary tumor size greater than 2 centimeter were taken. They are randomized in these four subsets: TH4 cycle, THP 4 cycles versus SP 4 cycles, and TP for 4 cycles, followed by surgery, followed by FEC in the first two groups, and then docetaxel followed by FEC, trastuzumab maintenance, and just a minute, and FEC 3 weekly, and then trastuzumab for 3 weekly maintenance for 1 year. Here, the primary endpoint was PAT-CR in the breast cancer patients with intention to treat analysis. And the second was stiffness study, where patients with operable locally advanced or infiltrate breast cancer with primary tumor more than 2 or 1 centimeter were taken. Here they were randomized into 3 subgroups, which was shown here, and PAT-CR assessed after surgery, and adjuvant treatment was completed with trastuzumab. And here the primary endpoint was cardiac safety. So, neoadjuvant pertuzumab, what were the PAT-CR rates? So, pertuzumab added to trastuzumab, as we can see here, increased the PAT-CR rate regardless of hormone status. So, this is what is proven by the new SPEAR study. And what Trihafna proved is that pertuzumab and trastuzumab provided clinical benefit regardless of chemotherapy partner. So you use FEC or you use TCHP, year through and through, it increased the benefit. So regardless of the chemotherapy partner and regardless of the hormone status of the tumor, if it is a HER2 positive tumor, pertuzumab will increase the PAT-CR rates. This is Neosphere and the Trihafna study. So same was reflected in the NCCN guidelines, as we know, in 2025, that TCHP is one of the preferred new adjuvant regimens, and all the new adjuvant preferred regimens are non-anthracycline to avoid long-term cardiotoxicity of these drugs and with equal efficiency. Now coming to what is the future landscape. So this is FAIR against study. Here dual HER2 with chemo de-escalation was the main concern. It is a multicentric randomized open label study with non-comparative phase 2 trial. Women with newly diagnosed HER2 invasive operable stage 1 to 3 A early breast cancer, tumor diameter more than 1.5 centimeter by MRI or ultrasound were taken with at least one or more PET available lesions. Because here what they have done something like Hostings, they have done PET adapted therapy. Here there is also certification with HER2 with the HR status. Group A was TCHP into 2 cycle followed by PET scan, and Group B here PH, there is trastuzumab plus like Herceptin plus pertuzumab was taken with the endocrine therapy if it is HR positive for 2 cycles, then PET. If response, if and no response, there's no response, TCHP it was escalated to TCHP. If there is response, same treatment was continued. And in Group A, they completed the standard 6 TCHP cycles and surgery was done. And then depending upon whether it is Group A and Group B, Group B continued with the standard adjuvant treatment. Group B, if there is no response and TCHP was escalated, then pertuzumab and trastuzumab was given with ET for 10 cycle, and entire year's maintenance was completed with hormone. And if there is a response, here, if there is a PAT-CR, then with no chemotherapy, only trastuzumab and pertuzumab with ET was given. If there is no PAT-CR, then there is escalation. Then post-op TCHP was given for 6 cycle, and then followed by the standard maintenance. Primary endpoint of this study was PAT-CR in PET responders Group B and the 3-year IDFS. Key secondary endpoint in PAT-CR in Group A and B, 3-year IDFS in Group A, 3-year DDFS in Group A and B, 3-year UFS and 3-year OS, and the safety, of course. And the PET responders were defined as disease response following 2 cycles with SU max reduction of 40 or more %. So what I found here is that the PET response after 2 cycle into group cycle 2 in Group B. Here, PET response was there in 80% and non-PET responders were almost 20%. And primary endpoint that pathologically complete response assessed in 18 in PET responders in Group B. Comparison of this is what they have shown over here. Comparison of pathological complete response between treatment groups in this pathologically complete response according to treatment group and FDG PET response in this. And Group A was TCHP and Group B was only HP with plus minus endocrine therapy. And here are the key efficiency endpoints. 3-year IDFS, mainly this is the standard arm, our TCHP arm, and this is the PET arm. Here, PET arm without, like this is without chemotherapy, and you can see there is not much difference between these two arms. More or less, some only minor differences. So, what was the investigator's conclusion here? That the phase 2 Fergen trial met its second primary endpoint in patients with HER2 positive EBC treated according to the PET-based response adapted strategy with 3-year IDF has been 95.4%. 3-year IDFS was 98.8% on patients with PET response and PAT-CR treated solely with pertuzumab and transmitters and no chemotherapy at all. There were no unexpected safety signals. Investigators concluded that PET-based response adaptive strategy identifies approximately 1 in 3 patients with HER2 positive EBC who can safely omit chemotherapy and thereby significantly reduce toxicity. Now, coming to trials in the adjuvant setting. So presently, as we all know that the phase 3 affinity trial was there, where surgery, patients post-surgery, HER2 positive, early breast cancers, no prior invasive breast cancer or no prior anti-cancer treatment or radiation was taken, node positive with any tumor size, or N0 tumor size, but more than 1 centimeter, and the baseline cardiac function should be normal. They were randomized into HER2 trans2 plus chemo versus placebo plus trans2 plus chemo. Up to 52 weeks was given, and then 10-year follow-up was done. And the primary endpoint was IDFS, secondary endpoint being OS, distant recurrence-free survival, DFS, RFS, safety, cardiac safety, and HR-rated quality of life. So after 10 years, they have finally presented this in ESMO breast cancer, Munich, Germany, that adjuvant. This was the paper which they have presented. And here, what they have shown is that with intention to treat analysis, there is difference of only 1.8% in the final OS. But in node positive population, which is high risk, it is 2.7% benefit. And node negative, it is only 0.2% benefit. And what they have shown is that in with node node 1 or more positive, or ER negative but PR positive, which is slightly bad group as compared to ER positive and PR positive group, and ER negative and PR negative group also, the pertuzumab seems to be doing better. And that is what is reflected in the latest guidelines. If there is afferent surgery and it is node positive, what they want to highlight is if pertuzumab is added, if the node is positive, then pertuzumab is a preferred drug to be added to trastuzumab. Similarly, if it is HR negative and HER2 positive, PAT-CR is there, and node positive is there, we should add pertuzumab. If it is if negative, pertuzumab may be added or may not be added. So, what I want to highlight is node positive initially, pertu is a must. Other cases you might or you might not add. Same is for HR positive, HER2 positive, PAT-CR, node positive, you should add pertuzumab. So, coming to another paper from new adjuvant and adjuvant pertuzumab in HER2 positive EBC, the final analysis of the randomized phase of phase 3 FIONI trial. Here, the objective was to compare the efficiency, safety, and tolerability of adding pertuzumab to trastuzumab and docetaxel versus placebo in Asian patients. And what they have shown in this is that pertuzumab adding the total PAT-CR rate increases from 21.8 to 39.3. 5-year DFS increases from 75 to 86%. Locoregional recurrences decrease in pertuzumab. Distal mets without CNS mets also decrease. Interestingly, the CNS mets are more. I don't know why, but it seems to be more in this arm. And what is the future? Like it is already presented. I think the presentation is old. Like Destiny 50 trial here. Post surgery, there is escalation of TDXD versus TDM1, and we know that TDXD has done better in this. There is another trial, Compass HER2, where post surgery TDM versus TDM plus tucatinib is being given, and in metastatic setting. Since possibility time, I'm just trying to complete as soon as possible within the time. Here, Cleopatra trial, trastuzumab, docetaxel plus minus pertuzumab in untreated HER2 MBC. We all know that if OS improvement of 17 months is not seen so far with any other two HER2 trial, what they mean to say earlier. Overall response rate of 80%, median cycles of 24, and median docetaxel cycles were 8 in this time. And this is what is the old. Now it is going to change, and the first line, we know that TDXG is going to come. Then this is Destiny 09. Here, HER2 positive metastatic breast cancers were taken with asymptomatic or inactive brain mets, DFI of 6 months from last chemotherapy or HER2 targeted repeat neoadjuvant adjuvant setting were used. One prior line of ET for MBC was permitted. No other prior systemic treatment was permitted. Certification factor include de novo versus recurrence, HR positive or HR negative, and PIK3CM mutation detected or not. Here, randomizing to 1:1:1 ratio, TDXD versus plus placebo, TDXD plus pertuzumab, and the THP, which was and is like as per NCCN the standard first line treatment. Primary endpoint is PFS. Secondary key endpoint was OS. Other secondary endpoint was PFS, overall response rate, duration of response, PFS2, safety and tolerability. As this planned interim, there's a plan interim analysis and results are reported for TDXD plus pertuzumab and THP arms. And here, what they have shown is that the median PFS is 41 months, almost like 40.7 versus 26.9 months. OS data is not yet mature, but regulatory approval is pending. TDXD monotherapy arm results are not disclosed yet. Longer duration of therapy in first and toxicity, more physical and financial. Only 32% could take post-TXD therapy. Post-TXD analysis, PFS2 data is not yet mature. So whether TAS2 PER2 in first line coming to like TDXD plus PER2 is going to come in first line or not, we will see, and it will replace THP or not. So India is the privilege to have first PER2 biosimilar product. And here is a publication of phase 3 data of biosimilar pertuzumab, that is Sigrima. This is a randomized double-blind phase 3 study in India for comparing efficiency, safety, and pharmacokinetic data of pertuzumab biosimilar with Perjeta, which is the original molecule, HER2 positive MBCs. So uh, there's already paper published regarding this in clinical breast cancer. So what to conclude from all this data is that access to anti-HER2 agent is increasing. Trans2, PER2, TDM1, we have all, for this, we all have generic, which is much more less as compared to the original molecule. Eligible patients should be brought under the new adjuvant first approach, as like we have seen in Neosphere and Trifnia. De-escalation strategies are being explored extensively, and there will be part of the personalization coming time. Positive long-term data of pertuzumab in upfront adjuvant setting should be considered for node-positive patient. New data may add some confidence in adding pertuzumab in new adjuvant and adjuvant setting for continuation of the treatment. Trans2 Per2 taxane remain the undisputed standard as of now, but maybe as we know they might change in soon near future. Ongoing research may pave the way for new strategy in future. Thank you. Thanks for patient listening.
Thank you, Anu, for such a exhaustive this thing. I am sure it is not easy to complete in one lecture, complete or do this thing. So I will now request Dr. Lovin Wilson to talk on emerging IO in esophageal cancer.
Yes, sorry
Lovin is
to
the
interrupt you, sir. So due to an
hello.
emergency, Dr. Lovin won't be able to deliver the lecture.
Okay,
I
okay,
request you to please give the closing remarks, sir.
okay, great. Okay, so thank you everyone for attending this Onco Summit. I'll just summarize whatever we have discussed. So we have discussed the Indian data of Durvalumab and GemCis, which is despite of the heterogeneous population in Indian patient where more gallbladder cancers were treated, but still we are matching with the data of Durva GemCis, the international publication. So it's one of the most important standard of care, Durva and GemCis in biliary tract, that is being taken by Dr. Adwait. And then SCC, we have a very good panel discussion, and we are very much sure that Durva and Treme is the very good alternative or probably a preferred treatment over atazobave due to its logistic cost and hypertension and bleeding comorbidities are like less. The chances of complications are less. Then for breast, we know that there is HER2 positivity is quite changing now, and ultra low versus low versus 3 plus where to biopsy. And as Anup clearly pointed out, TDXD is coming in a big way in neoadjuvant, first line, and all other settings. So I think with that, uh, I will declare this Onco Summit to be over. If you have any question, I think there is one question in chat. I don't think. I think I have replied him. So I think thank you very much for attending this on this post Diwali session. I think good night, everyone.